Bismillahirrahmanirrahim. The thought of today is a new day. Even if you were wrong yesterday, you can get it right today. Assalamu alaikum. My name is Dr. Inshrah and I'm a PGR of Community Medicine and Public Health at King Edward Medical University, Lahore. Today, the topic of my presentation is chlamydia, and I'll be presenting it under kind supervision of Professor Dr. Saira Afzal. Our learning outlines will be Introduction to Chlamydia, History and Prevalence, its epidemiology, clinical features, diagnosis and treatment, prevention, global data, recent updates, and an MCQ. At the end of this presentation, the participants will be able to learn about Chlamydia trachomatis and its impact, understand Chlamydia's global and local prevalence, recognize Chlamydia's risk factors and patterns, identify symptoms and complications of Chlamydia, learn diagnostic methods and treatment options, and understand strategies to prevent Chlamydia. Introduction to Chlamydia. Chlamydia is a common sexually transmitted infection. It primarily targets the urogenital tract but can also affect the eyes and respiratory system. Many cases are asymptomatic, leading to underdiagnosis and complications. The causative organism is an intracellular bacterium with various reservoirs responsible for different diseases. Chlamydia is the most reported bacterial STI globally, with 129 million new cases in 2020. History of Chlamydia. In 1907, Halbert Stedet and von Provezek first identified Chlamydia trachomatis in conjunctival scrapings of trachoma patients. In 1966, it was reclassified as a bacterium based on its cellular structure and ability to replicate in host cells, distinguishing it from viruses. 1917 marked studies confirmed Chlamydia trachomatis as a major cause of non-gonococcal urethritis and pelvic inflammatory disease. In 1990s, there was introduction of nucleic acid amplification tests, improving the sensitivity and specificity of diagnosis. In 2000s, this was recognized as a priority infection for STI prevention program by WHO due to its high prevalence and reproductive health impacts. Global statistics. An estimated 129 million new cases of chlamydia were reported globally in 2020. The infection is most prevalent in individuals aged 15 to 24, particularly in women. Chlamydia accounts for a significant proportion of bacterial sexually transmitted infections worldwide. Prevalence studies in Pakistan remain limited, but Chlamydia trachomatis infections are more common in areas with low awareness of STI. Studies estimate that approximately 10 to 15% of sexually active women in reproductive age group are affected. Higher prevalence is reported in younger women 15 to 24 years and regions with limited access to health. Epidemiological triad include obviously the agent factors, the host factors, and environmental factors. Agent factors, the causative organism Chlamydia trachomatis is an obligate intracellular bacterium. It has multiple serovars. Serovar A to C causes trachoma, that is an eye infection. Serovars D to K cause urogenital infections, and serovars L1 to L3 cause lymphogranuloma veneris. Host factors. Influencing susceptibility includes age, highest prevalence in 15 to 24 years, gender. Women are more affected due to anatomical susceptibility, behavioral factors, multiple partners, and lack of valid contraception. Immune system and coexisting STIs such as HIV. Environmental factors include limited access to STI screening and treatment, low awareness and stigma surrounding STI, poor hygiene and healthcare infrastructure, especially in low-resource settings, overcrowded living conditions in some regions. This is an overview of chlamydia. Chain of transmission includes reservoir, portal of exit, mode of transmission, portal of entry, and susceptible host. Reservoir. Humans are the sole reservoir. Asymptomatic carriers play a key role in sustaining transmission. Portal of exit includes genital secretions, including semen and vaginal fluids, and infected birth canal during childbirth. Modes of transmission includes direct, vertical, or rare mode. Portal of entry includes mucosal surfaces of the genital tract, rectum, oropharynx, and conjunctiva. Susceptible hosts are sexually active individuals, neonates born to infected mothers, those with compromised immune systems or co-infections like HIV. Mechanism of spread by sexual contact, primary mode of transmission via unprotected vaginal, anal, or oral sex. Asymptomatic cases significantly contribute to silent transmission. Mother to child. Vertical transmission occurs during childbirth, may result in neonatal conjunctivitis or pneumonia. Rare modes include indirect transmission through contaminated hands touching the eyes, causing trachoma, rarely via contaminated instruments or surfaces. Understanding these mechanisms highlights the importance of screening safe sexual practices and perinatal care to prevent spread. Incubation period and period of infectivity. The incubation period for Chlamydia trachomatis is typically 1 to 3 weeks after exposure. Symptoms may develop within this period, but many individuals remain asymptomatic, which contributes to silent spread of the infection. Period of infectivity. Individuals remain infectious as long as the infection is untreated, which can last for months. In women, the infections can persist in the cervix and fallopian tubes, while in men, it can persist in the urethra and epididymis. Asymptomatic individuals can still spread the infection. After treatment, they are generally no longer infectious 7 days post-treatment. Risk factors for STI. Individual risk factors and then socio-cultural factors. Individual risk factors include the age, highest prevalence in individuals aged 15 to 24, particularly young women. Sexual behaviors include multiple sexual partners that increases the risk of exposure, lack of condom use or inconsistent condom use during sexual activity. Early sexual debut before age 18 is associated with a higher risk. Previous STIs or co-infections such as HIV increases susceptibility. Sociocultural risk factors include cultural and social norms. Stigma and lack of open discussion about STIs can discourage testing and treatment. Limited access to healthcare, inadequate sexual health education, and access to preventive services in some regions. Poverty and overcrowding. Poor living conditions and limited healthcare resources may contribute to high infection rates. Clinical picture. Early stage infections with Chlamydia trachomatis frequently have little or no symptoms. Even when signs and symptoms appear, they are frequently minor, making them easy to detect. However, certain Chlamydia symptoms may differ somewhat between men and women. These are some of the general signs and symptoms that are found in the patients of Chlamydia. Symptoms in men. Most males showed no signs or symptoms at all. The following are some of the men's most prevalent Chlamydia symptoms. Yellow or greenish discharge from the penis, pain in the lower abdomen, pain in the testicles, burning sensation during urination. Symptoms in men. Symptoms in women. Some of the most common Chlamydia symptoms in women are as follows. Painful sexual intercourse, that is known as dyspareunia, pain in the lower abdomen, burning sensations during urination, inflammation of the cervix or cervicitis, bleeding between periods, or vaginal discharge. Chlamydia may infect the rectum as well. Rectal discomfort, discharge, and bleeding are the all possible signs of a rectal infection. These are some of the signs or symptoms found in women: fever and sore throat, itching around the vagina, abdominal or pelvic pain, vaginal discharge or bleeding, painful urination or intercourse. Here are the signs and symptoms for men: painful urination or intercourse, discharge from the tip of the penis, pain or swelling in the testicles, fever and sore throat, and inflammation of the foreskin. Symptoms in infants: ophthalmia neonatorium, neonatal conjunctivitis, redness, swelling, and discharge from the eyes, typically within 5 to 12 days after birth. Mucopurulent discharge may cause eyelids to stick together. Possible corneal scarring if left untreated. Symptoms in infants includes pneumonia too, cough, tachypnea, nasal flaring, chest retractions, and labor breathing. Mild fever and irritability. Pneumonia caused by Chlamydia trachomatis can be severe if untreated, leading to hospitalization in some cases. Complications in untreated cases. Complications in women include pelvic inflammatory disease, ectopic pregnancy, increased risk of HIV, infertility. In men, it includes epididymitis, urethral strictures, recurrent infections, increased risk of HIV, and infertility. Chlamydia and other STIs, co-infection. Co-infection with gonorrhea, Chlamydia trachomatis and Neisseria gonorrhea often occur together, especially in individuals who engage in high-risk sexual behavior. Co-infections can increase the risk of severe complications such as PID, infertility, and ectopic pregnancy. Additionally, co-infected individuals may have a high risk of HIV transmission due to increased inflammation and ulceration of genital tissue. This is a picture that compares chlamydia with gonorrhea. Both of these are spread by unprotected sex. Appearance of symptoms after exposure includes 2 weeks in chlamydia and 7 days in gonorrhea. Vaginal symptoms in patients with chlamydia includes bleeding with sex, bleeding between periods, scanty, watery, transparent discharge with foul smell. While in gonorrhea cases, there is abundant yellowish thick discharge. Urethral symptoms in chlamydia include minimal burning with urination, minimal urethral swelling and redness, minimal watery transparent discharge. While in cases of gonorrhea, there is significant burning with urination, significant urethral swelling and redness, significant thick yellow urethral discharge. Co-infections with syphilis. Syphilis and chlamydia may coexist with both infections presenting with overlapping symptoms, making diagnosis and treatment more challenging. Before infections can contribute to severe complications if left untreated, including heart disease and neurological damage for syphilis and reproductive health issues for chlamydia. Chlamydia and HIV. Chlamydia increases susceptibility to HIV by increasing genital tract inflammation, which facilitates HIV entry. It also raises CD4 positive T cell concentrations, the primary target of HIV. Chlamydia infections can enhance HIV transmission by increasing viral loads and causing genital ulcerations, providing entry points for HIV. Clinical implications include, in HIV-infected individuals, chlamydia may worsen outcomes leading to complications. It may accelerate HIV progression by activating the immune system and increasing immune exhaustion. Co-infected individuals require prompt treatment and close monitoring for both conditions. Prevention includes regular screening for both infections, consistent condom use that reduces the risk of transmission. Chlamydia in pregnancy includes risks to the mother. Pelvic inflammatory disease and preterm birth are more likely in untreated infections. Chorioamnionitis, infection of the amniotic sac, may occur, leading to premature rupture of membranes. Risk to the fetus or newborn includes neonatal conjunctivitis and pneumonia that can develop if the infant is exposed during vaginal delivery. Low birth weight may be associated with untreated chlamydia. Guidelines for screening and treatment. Screening includes pregnant women under 25 or at high risk should be screened at the first prenatal visit and retested in the third trimester if at high risk. Treatment includes azithromycin 1 gram single dose, that is the recommended therapy, and ensure partners are also treated to prevent reinfection. Diagnostic tests include nucleic acid amplification test, that is the gold standard for chlamydia diagnosis. It detects Chlamydia trachomatis DNA or RNA with high sensitivity and specificity. Sample types include urinal, vaginal swab, and urethral swab. Other methods include microscopy, that has low sensitivity and is rarely used today, and serology, useful in research or diagnosing chronic infections but not ideal for acute infections due to lower accuracy. Treatment options include first-line options that are azithromycin 1 gram orally as a single dose, doxycycline 100 milligram orally twice daily for 7 days. Alternative regimens include erythromycin for individuals intolerant to first-line options. Levofloxacin or ofloxacin may be used in specific cases based on susceptibility. For special populations like pregnant women, azithromycin is preferred due to safety and efficacy. Neonatal infections, erythromycin or azithromycin for neonatal conjunctivitis or pneumonia. Key considerations include abstain from sexual activity until treatment is complete. Partners are also treated. Follow-up testing recommended for reinfection prevention, especially in high-risk individuals. Partner management for chlamydia includes treatment of partners. All recent sexual partners within 60 days of diagnosis should be notified, tested, and treated regardless of symptoms. Same treatment regimen, that is azithromycin or doxycycline, are recommended for partners. Education and counseling. Inform partners about the infection, transmission risk, and the importance of treatment and follow-up. Reinforce safe sex practices and consistent condom use to prevent reinfection. Follow-up. Retesting for the index patient and partners after 3 months to ensure clearance and prevent reinfection cycles. Expedited partner therapy. EPT involves prescribing treatment for the sexual partners of individuals diagnosed with chlamydia without requiring a clinical evaluation. The patient receives medications for their partner or partners and is educated on treatment and potential side effects. Its benefit includes reduce in reinfection and transmission, overcomes barriers to partner healthcare access like stigma and logistical challenges, ensures compliance with local regulations, and includes follow-up to confirm partner treatment. Repeat testing after treatment for chlamydia. Retesting is recommended for all patients and partners treated for chlamydia trachomatis. Intervals for follow-up are routine retesting 3 months after treatment, regardless of symptom resolution. For pregnant women, retesting during the third trimester, and then in case of persisting symptoms, immediate follow-up testing to rule out treatment failure or reinfection. Key considerations include use nucleic acid amplification test for follow-up due to high sensitivity. Psychological impact of chlamydia. A diagnosis of chlamydia may lead to anxiety, shame, and feelings of stigma, which may affect mental health. Individuals may worry about future fertility, relationship issues, or the social consequences of having an STD. Psychological counseling and support should be integrated into care to address emotional distress and encourage adherence to treatment and preventive measures. Primary prevention includes safe sex practices, promote condom use, regular STI screening, and education on reducing risk behavior, community awareness by public campaigns and education programs that focus on prevention targeting youth and underserved populations. The goal is to prevent new infections through awareness. Secondary prevention includes early diagnosis by regular screening for at-risk individuals, especially asymptomatic cases, contact tracing by identifying and notifying sexual partners of infected individuals to prevent further spread and to ensure timely treatment. Treatment includes prompt administration of antibiotics to eliminate infection. The goal is to break the chain of transmission and minimize long-term health consequences. Tertiary prevention includes managing complications by providing treatment for conditions like PID, infertility, ectopic pregnancy, and chronic pelvic pain in women, and epididymitis or prostatitis in men. Rehabilitation by support patients with counseling, fertility treatments, and long-term care to manage and mitigate the effects of complications. The goal is to improve quality of life for affected individuals. Some other information includes chlamydia is a public health concern. Economic impact of chlamydia. Chlamydia imposes significant economic costs through healthcare expenses for treatment and complications. Uncomplicated or undiagnosed cases lead to long-term health issues and productivity loss, especially among young adults. Health burden. The disease contributes to reproductive health problems, with many cases being asymptomatic, leading to silent transmission. Chlamydia increases the risk of co-infections such as HIV, complicating public health efforts. Global efforts in chlamydia control. WHO initiatives that promote sexual health programs focus on STI screening, prevention, and education, especially for young people. Prevention strategies, public health campaigns that emphasize safe sexual practices and regular screening targeting high-risk populations for early detection. Screening programs, routine screening for sexually active women under 25 in many countries with EPT to reduce reinfection. Global partnership, collaboration between government, NGOs, and international bodies for prevention and treatment programs. Vaccine research, ongoing efforts to develop a vaccine for chlamydia trachomatis. Role of healthcare providers in chlamydia control. Healthcare professionals must be trained in recognizing symptoms, diagnosing, and managing chlamydia effectively. They should be familiar with clinical guidelines, including appropriate testing methods, treatment regimens, and partners management strategies. Ongoing education and ensures healthcare providers stay updated on the latest research, best practices, and prevention strategies for STI. Cultural factors affecting chlamydia prevention in Pakistan. Sociocultural influences such as taboo around discussing sexual health and a lack of awareness hinder effective prevention and treatment. Traditional gender roles and societal stigma may discourage individuals from seeking care, especially for women and adolescents. Cultural norms that prioritize family honor over individual health can prevent open communication about sexual behavior and STI prevention, contributing to underreporting and delayed treatment. Moving forward to the recent updates, reproductive tract complications risk following chlamydia trachomatis infection, a long-term prospective cohort study from 2008 to 2022. This study was published in October 2024 in The Lancet. The clinical and public health relevance of widespread testing for asymptomatic chlamydia trachomatis infection is under debate. A cohort of 5,704 reproductive age women recruited from a chlamydia screening study was followed up for a period of 14 days. Chlamydia positivity was determined using screening polymerase chain reactions test results, self-reported diagnosis with or without symptoms, chlamydia immunoglobulin G antibody. During 1,04,612 procedures, 2,103, that is 36.9% women were chlamydia positive, and 3,692 women, that is 64.7%, had been pregnant at least once. Risks for PID, ectopic pregnancy, and tubal factor infertility were 1.62, 1.84, and 2.75, compared to chlamydia negatives. Adjusted hazard ratios for PID after symptomatic and asymptomatic infection were 2.29 and 1.07 respectively. Incidence of PID, ectopic pregnancy, and tubal factor infertility after symptomatic chlamydia infection remained low with rates per 1,000 percentages of 5.8, 1.9, and 1.8 respectively. We found a significantly higher risk of PID, ectopic pregnancy, and tubal factor infertility in chlamydia positive women compared to chlamydia negative women, although the overall incidence rate of complications remains low. Advances in vaccine development for chlamydia trachomatis. Antibiotic treatment is highly effective, but infection is often asymptomatic, resulting in most individuals going undetected and untreated. Chlamydia screening and treatment programs have failed to control this epidemic and demonstrate the need for an efficacious vaccine to prevent transmission and disease. Animal models and human epidemiological data reveal that natural immunity can provide partial or short-lived sterilizing immunity. These data further demonstrate the importance of eliciting interferon gamma, producing cluster of differentiation 4, that is CD4 T cells that can likely synergize with antibody-mediated opsonophagocytosis to provide optimal protection. These studies have guided preclinical rationale vaccine design for decades, and the first phase 1 clinical trials have recently been completed. Recent advances have led to improvements in vaccine platforms and clinically safe adjuvants that help provide a pathway forward. Neighborhood societal vulnerability and access to expedited partner therapy prescription, a secret shopper audit service. Expedited partner therapy, EPT reduces STI reinfection rates by enabling treatment of partners without requiring medical visits. However, in the era of electronic prescribing, EPT utilization remains low, hindered by pharmacists' unfamiliarity and logistical challenges. The objective of this study was to evaluate pharmacists' awareness and willingness to dispense electronic nameless EPT prescriptions in New York City pharmacies and examine associations with socioeconomic sectors of pharmacy locations. Of 335 responding pharmacies, 40% of pharmacists were aware of EPT and 30% were willing to fill nameless prescriptions. Awareness was higher among national chain pharmacies compared to independents. Most pharmacies, 86%, accepted insurance for EPT prescriptions, but dispensing frequently occurred under index patients' needs in 34%. Only 30% adhered to nameless EPT guidelines. Common barriers to dispensing included unfamiliarity with EPT, 62%, and the Mistaken belief that patients' names were legally required 28%. Adjusted models showed higher EPC awareness in areas with greater socioeconomic vulnerability, highest SVI quartile or 3.7, but willingness to fill prescriptions did not vary by SVI. Now the MCQs. A 22-year-old woman with no prior medical history is screened during routine checkup. Despite being asymptomatic, her test returns positive for chlamydia trachomatis. Why is routine screening especially emphasized in individuals in this group? A. They are at higher risk of antibiotic resistance. B. They represent the highest burden of infection globally. C. They have more severe clinical presentations. D. They are less likely to transmit the infection. Or E. They frequently develop trachomas. The correct answer is yeah. A healthcare worker in an urban clinic is tasked with addressing STI prevalence in women of reproductive age. Considering local prevalence studies, which intentions would most effectively target the at-risk population? A. Distributing antibiotics without prescription in urban areas. B. Offering routine STI screening in rural healthcare centers. C. Focusing educational programs on men aged 20 to 40 years. D. Promoting STI awareness campaigns among women aged 15 to 29 years. Targeting individuals over 40 years with STI prevention programs. The correct answer is Delta. A 30-year-old woman from a rural area presents with bilateral eye redness and discharge. Examination shows conjunctival scarring and trichiasis. She recalls similar symptoms in her community, especially among children. Which serovirus of Chlamydia trachomatis are most likely responsible for her condition? A. Serovirus A to C. B. Serovirus D to K. C. L1 to L3. D. M to N. Or E. P to Q. Correct answer is alpha. A 23-year-old woman reports symptoms of dysuria and vaginal discharge. She engages in unprotected sexual activities and has a new partner. Which of the following increases her susceptibility to chlamydia trachomatis infection? A. Use of hormonal contraceptives. B. Co-infection with HIV. C. Previous vaccination for HPV. D. Lack of travel history. Or E. Advanced age. The correct answer is D. A 16-year-old girl engages in sexual activity and presents with pelvic pain. Her early sexual debut and lack of STI education are noted. What strategy is most effective in reducing her risk for future STI? A. Improving living conditions. B. Reducing stigma around STI. C. Routine partner screening. D. Mandatory annual STI testing. Or E. Comprehensive sexual health education. Correct answer is Eta. A 23-year-old man visits a clinic with complaints of a burning sensation during urination and yellow benign discharge. He denies any other symptoms but has had unprotected sexual encounter with multiple partners. Which is the most likely diagnosis? A. Gonorrhea. B. Herpes simplex virus infection. C. Chlamydia trachomatis infection. D. Syphilis. Or E. Trichomoniasis. Correct answer is Charlie. A 35-year-old man with co-infections of Neisseria gonorrhea and Chlamydia trachomatis presents for follow-up after treatment. Why is it important to counsel him about HIV prevention strategies? A. Co-infection directly causes HIV. B. Co-infection suppresses the immune response, making HIV inevitable. C. Co-infection delays HIV seroconversion. D. HIV can only be transmitted if co-infections are present. D. Co-infection increases genital inflammation, raising the risk of HIV transmission. Correct answer is Eta. A 29-year-old pregnant woman is diagnosed with chlamydia during her second trimester and successfully treated with azithromycin. She expresses concern about reinfection. Which key steps should the clinician recommend to reduce the risk of reinfection? A. Avoiding screening during pregnancy. B. Treating only the index patient. C. Using barrier contraceptives after childbirth. D. Ensuring her sexual partner is also treated. E. Delaying treatment until postpartum. The correct answer is delta. A 30-year-old man presents with a complaint of a burning sensation during urination and mild discharge from the rectum. He is suspected of having a chlamydia infection. Which of the following diagnostic method is most suitable for confirming the diagnosis due to its high sensitivity and specificity? A. Urine culture. B. Nucleic acid amplification test. C. Gram stain. D. Serological testing. E. Direct microscopy of the discharge. Correct answer is beta. A 25-year-old woman is diagnosed with chlamydia and is prescribed treatment. She is instructed to notify her sexual partner and is offered medication for the partner without requiring a clinical evaluation. Which of the following is the primary benefit of this approach? A. Reduces the risk of reinfection and transmission. B. Increases the likelihood of reinfection. C. Eliminates the need for routine screening. D. Allows for faster diagnosis of chlamydia. Or E. Guarantees that all partners are tested for chlamydia. The correct answer is alpha. This is the key to all MCQs. This is the link to our YouTube channel where all these presentations are uploaded. Thank you for your attention.